So today we have an interesting talk on multi-channel delivery in healthcare and the impact of telemedicine centers in southern India. So when we look at telemedicine, our teleophthalmology is like a virtual patient care, and in fact, World Health Organization defines as a healing from a distance, and using either audio or visual technological solutions. So first teleophthalmology project is actually way back in 1987, and interestingly, it was due to the fundus images of the astronauts through the Columbia flight were actually transmitted, and the images were actually read, and then to know the changes in the retinal circulation of these astronauts, and that was the first telemedicine project in 1987. So, however, even though we had all the science that is available to the telemedicine and all the technology was available, and you can very interestingly, you can see that if you just put teleophthalmology in India in PubMed, so we can say that pre-corona and post-corona, there is a stark difference, like how our Charminar was there pre-corona, and now, of course, we have come back to that stage. But pre-corona, it was mainly limited to primary eye care, and also the specialty models like diabetic retinopathy. And those were the models that were existing. However, what happened was the pandemic given us a very big opportunity for us to integrate telemedicine in various ways, integrating into care pathways, both primary, secondary, and tertiary levels. And this is what the pandemic actually shown the advantage of telemedicine. So briefly, we can say that telemedicine can be like between specialist and non-specialist communication. So that typically happens in primary healthcare centers and primary eye care centers. And it could be a specialist to specialist communication. And we all know that the advantages of telemedicine or teleophthalmology is that it can, we can have expert advice, and it has the advantages of it can actually reduce the barriers of the distance, time, and money. And also it can also has a significant environmental impact in the form of reducing the carbon footprint. And it has a definitely an equitable, sustainable healthcare system when we integrate them in the pathways. So today, to speak about the impact of telemedicine, I think we have a distinguished guest speaker with us today, Professor Sarang Dio, and he is Management and Executive Director of Max Institute of Healthcare Management at the Indian School of Business, and recently has been appointed as a Deputy Dean for Faculty and Research at ISB. And he has a PhD from UCLA Anderson School of Management, and his research focus is healthcare delivery systems and the impact of operational decisions on population level health outcomes. And he has regular collaborations with prestigious implementation grant agencies such as Bill and Melinda Gates Foundation, Clinton Health Access Initiative, and Path for Research. We really look forward to your talk today, Professor Sarang. Welcome.
Thank you, Dr. Padmaja. I didn't know you will spring up Deputy Dean on me, but this is a researcher's hat today, not an administrator's one. Let me share my screen. So thank you. I think I learned today about the first teleophthalmology consultation. I never knew that. I mean, some of the collaborators that you mentioned, Dr. Padmaja, one of them is actually LV Prasad itself, and then the other one that I'll talk about today is Arvind. I greatly admire both institutions and the operational innovations that they undertake. So, it has been a privilege and pleasure to work with these organizations and learn from them. So this particular project that I'm going to talk about today started many years ago, actually around maybe 2015, and is really the work of a PhD student from London Business School, Craig Delana, who graduated since and now has moved back to Europe as a faculty. And then my collaborator at London Business School, Kamalini, as well as our collaborators at Arvind, Ganesh Babu, who is head of their operations now. I think he was head of their IT then, and Tulsi Ravila, who many of you may know. He's the director of LICO, their Community Ophthalmology Institute. So, I mean, to be honest, when we started this project, we were under the impression that Arvind camp model is hugely successful. Only when we started talking to them, and by the way, in business schools, we teach this case study on Arvind Eye Care and how camp is a big innovation. And when we talked to them, they said, well, you know what, we learned a long time ago that camps have a very limited impact when it comes to access. And in response to those limitations of camps, we started this vision center model or telemedicine model. And the first thing we did as business school faculty is start, a teaching case study on what's the difference between this model and the camp model on various dimensions: cost, access, quality, also patient behavior. So how would patients react differently to a temporary camp that is set up once in a while versus a permanent installation, which these vision centers are? And I think after we wrote this case study, we realized that there is a lot more that we can investigate more rigorously using data. The original goal then was to understand relative cost effectiveness of these two channels, because telemedicine centers require fixed investment, fixed costs, whereas camps, you can think of them as semi-variable, semi-fixed. And so that was the original starting point, I think. But before we could do that, we realized that we wanted to understand basic impacts of these vision centers on patient flows. So that's what this paper ended up being eventually. The paper is published now in Management Science. It's a management journal. Some of you may or may not be familiar with this, but I'll share the link later, which can be distributed. I have to share this story that when I first started working with clinical collaborators, they were very surprised that there are such journals that publish papers only on waiting times and only on queues. And I had to say, yes, that's our bread and butter. So I think now we've come a long way that there is much more collaboration across the two sides. Also, the title of the paper that you see, Multi-Channel Delivery in Healthcare, to be honest, we were not sure how relevant or how interesting management audience will find telemedicine. As you can see, this paper was written up before COVID, as Dr. Padmaja said. At that time, telemedicine was, okay, it's there. And so we tried to use this multi-channel delivery as, some way to attract management researchers to this idea. Since then, I think telemedicine is much more mainstream now. So, okay, so this is some of these slides are, from a management perspective. So allow me a little bit of broad generalization, and then I'll jump to the context. If I look at what telemedicine, teleophthalmology is, it's really an innovative operating model to improve last mile connectivity, right? Overcome this last mile challenge of getting to the patient if the patient cannot get to you. So what I'm showing here is roughly on the left-hand side, you see mobile phone-based delivery. And on the right-hand side, what you see is the old mobile delivery, right? Where mobile vans would go, or a community health worker would go as a mobile health resource. And what is in the middle is what I think is this type of a telemedicine setup, okay? Which is, it's not really the convenience of smartphone-based telemedicine, because these patients that one is trying to target may not have smartphones, or if they have smartphones, they may not know exactly how to use an app on a smartphone, so on and so forth. So there is a fixed installation to which patients are coming, and this fixed installation is closer to their residence than a conventional place of care delivery. But resources also need to go to this fixed installation. So it's somewhere in the middle. I mean, something that is as natural as this in our setting, we had to take a lot of effort to explain to an international audience, because for them, telemedicine usually means just sort of taking a phone and talking. And you will see later that this feature of a fixed installation or fixed base telemedicine has a lot of implications on the findings and results. So just hold on to this thought until I come to the results. And then there is, of course, a lot of work on telemedicine in low middle income countries, especially. WHO has several documents, a whole global observatory. Of course, there's also an HBR article on this. What is though, and of course, health affairs too. But I want to point out this excerpt from this WHO Global Observatory document, which at that time said that while a lot has been written on telemedicine, there are very few rigorous evaluations of the impact of telemedicine, and more from a process point of view. So what really changes in the healthcare delivery process, what changes in the way patients perceive and react to this new model or channel of healthcare delivery. So we thought we could add to that because of our operations background. And if I wear that hat of an operations researcher or an operations person, networks is something that comes to us naturally. So both at LV Prasad and Arvind, you can think about these different telemedicine centers as really expanding a network of healthcare facilities. And if someone is designing that network, a bunch of questions come up, okay? The hub and spoke arrangement. So one basic fundamental question is, what capability should these spokes have? I mean, now there is discussion of these spokes should have a fundus camera, right? And maybe have an AI-enabled fundus camera, but it's a moving target. And one could have said, oh, all you need is just basically a computer that connects the patient to a doctor. But also from a human resource point of view, what kind of human resources do you need in this spoke? All of these are decisions which either we make automatically or we think carefully and deliberately about. How many telemedicine centers should be supported by one hub, call it a base hospital or a secondary center or what have you. And then also, where should telemedicine centers be located? Okay, I think there's some chat questions. I'm going to hold off on them. Dr. Padmaja, I don't know what the...
We can actually take in the end once your talk completed.
Yeah. And the question is about AI. We'll
Yes.
definitely hold it until the end because my talk will not be about AI at all. It was just a passing reference. But the point being that all of these network design decisions, very important ones, need some underlying information to answer these questions rigorously. And those informational questions or empirical questions are, how will patients respond to this new channel of care? Will they adjust their visits to the older channel, which means a physical channel of a hospital? And how will these effects be different for different types of patients? Of course, what will happen to outcomes of these patients? And would these effects vary by distance? This is where the fixed base telemedicine model becomes important. And so as operations researchers, the questions on the left are of interest as a system design person, but we realized that we couldn't even answer those questions until we had answers to the questions on the right. So more specifically, we said, okay, here is a picture, okay, a canonical town or a village, which is in blue here. People from this town or village were going to a hospital very far away. But now this yellow telemedicine center or a vision center has opened up closer. So now what are all possible effects on people's behavior here? Some of the visits that were happening to the hospital now may start happening at the telemedicine center. This is what we call as substitution. Okay, so you can think about simple ailments for which people were going far away or they did not know these were simple ailments, now may substitute those visits at the telemedicine center. Second is some problems that seem so minor that no care was being sought by patients from this town could now go to telemedicine center because it's easy to go. So even for a minor problem, I can just drop it. And this is what we can call as demand augmentation. So demand may overall increase. Some demand may get substituted from the hospital. And once patients show up at the telemedicine center, then some referrals may get generated. These we call as complementarities. And so if you look at the hospital will continue to get some non-substitutable demand that cannot be served by telemedicine center. But some demand or some patient flow at the hospital may drop because of substitution by telemedicine center. And some volume may increase actually at the hospital because of these complementarities or referrals. So suffice to say that the picture of how the flows will change is quite complicated. And so it's important to tease this apart, because imagine an extreme case where all the new quote unquote volume of patients that the telemedicine center gets is purely a substitution effect. And there is really no demand augmentation. that will have a different implication for cost effectiveness of a telemedicine center, as against a scenario where almost all of the volume that the telemedicine center gets is demand augmentation. So I'm talking about extremes. But to answer the original question of what is contribution of a new telemedicine center or a cost effectiveness of a telemedicine center, knowing these substitution effects, demand augmentation effects, referral effects is important. And that's what we ended up doing empirically, rigorously in this project. Okay. So that's what I said. Direction and magnitude of these different effects will determine the cost effectiveness of this new channel. Our study context, I'm sure most of you are very familiar with the study context. When we began working with Arvind, at that time, they had 5 tertiary care centers, 6 secondary care centers, some community eye clinics, and then roughly 54 primary care vision centers, telemedicine centers, which I think now are touching maybe 90 or 100. And those who are not very familiar with the vision centers at Arvind, I'm given to understand that they are very different from LV Prasad's approach to vision centers. Most of these Arvind vision centers operate not in remote tribal areas or completely rural areas, but in smaller towns that have a certain catchment population of about 25,000 in a 5-kilometer radius. Okay, so if you were anchoring your thoughts on LV Prasad's vision centers, just change it a little bit in your mind. So this is a visual map of what the network looked like for the Madurai base hospital on which we focus. So out of the 54 vision centers that I showed you earlier, we looked at roughly 20 vision centers that were connected. So this is the hub and spoke, connected to the Madurai base hospital. And this blue line or blue circle here denotes the catchment area of a secondary center that opened in Dindigul around the time of our study period. I mean, the data that we have for. And so if you were to just ask a very broad question, how did patient flow or volume change over the time period when these vision centers opened, you will see that there is an overall increase in the volume of patients to Madurai Hospital. This is the blue line. And of course, as vision centers opened, more and more people visited vision centers, and something is happening at this Dindigul center, right? So this very, very high level aggregate data really doesn't allow you to answer those very nuanced questions about complementarity, substitution, etc. Because there is a secular trend of volume increasing day by day, which I'm sure at LV Prasad you have also experienced. So how do you then answer those original questions about substitution and complementarities? Well, an ideal approach would be, some people would argue, do a field trial. So what field trial would mean is there are hundreds of candidate locations where you can open a vision center, randomly select some locations and open a vision center, and compare to other similar locations that you did not give a vision center to. Now, that kind of a randomized trial to open a vision center is completely impractical, right? Because there are a lot of investments involved. You have patients to serve. And so, on some level, actual delivery of care is far more important for you than just experimenting to learn certain effects, right? So we cannot, in this context, run the first best randomized control trial. And so what we will do instead is do a quasi-experimental thought process, okay, thought experiment, which is, what I really want is a counterfactual. There are certain locations that got a vision center. We cannot control which locations got the vision center. I'm looking retrospectively. But I'm asking the question, what would have happened in those locations that got the vision center if they had not got the vision center, which is what we call as counterfactual, right? And when I say what would have happened, I'm basically saying, how would the patients have behaved from those locations where the vision center opened if a vision center had not opened? And the way to create this counterfactual, not really, but virtually, is to think about similar, quote unquote, similar patient locations, which did not get the treatment, meaning the vision center. And the way to do that is, so what you see here on the right hand side is, say, a control village and a treated village. When I say similar locations, what I'm saying is that the trend of visits or patient volume in these treated and control villages should be similar, should be parallel. They don't need to be identical, the trends, but they need to be parallel over time. And so let's say the treated village, there is a change that you can observe because the vision center actually opened here. And the control village is similar to the treated village, but it did not get a vision center. And so the trend here would continue. And so then this difference, this change that happens in one but not in the other of the parallel trends, will give us the effect, will give us the counterfactual of what is the impact of vision center on multiple outcomes. Okay, so now to note here is, whatever I'm proposing, the quasi-experimental setup or difference in differences, will not work if the trends are not parallel to begin with. So this parallel trend assumptions turns out to be very important in settings where I cannot actually randomize and run an experiment, but I'm relying on quasi-experimental setup. Okay, so let me show you briefly how we did this, how we chose similar villages or similar patient locations. For that, the data that we had was medical records from Arvind over a long period of time, about 10 years, roughly from the time they got the first vision center to the time we started our study. Very large data set, 2.5 million distinct patients, 5 million visits. So roughly 2 visits per patient over the time period. Again, you know that there's going to be a high variation. Okay, some patients are going to have multiple visits, and some patients are going to have, a lot of patients are going to have only 1 visit. For each patient, we obviously had an ID, which is very good. And we had an address. This will turn out to be quite important. And then we had the diagnosis and the treatments that were given to them, money that was charged to them, cost to the patient, and some basic measures of visual acuity. We took that data, especially the address data, and mapped it to the census data from India, because we thought it was very important for us to pin down a patient to a geographic location, and no pun intended here. You see a lot of pins, right? Blue and red pins. So what are these? Each pin here on the right diagram is a census location. So we are going to map patients to census locations, and then we are going to map the census locations to the catchment area around a vision center. So all the red pins here are falling within the catchment area of a vision center in our study sample. And the blue pins are those which are beyond the catchment area. So you can think about the blue pins as all census locations that are potentially controlled, potentially, not actually, potentially controlled. And then we are going to try and pick only those blue pins which match with the pink pins or the red pins on certain dimensions. Those dimensions could be road connectivity, medical facilities available, median income levels of population, or how far away are they from an all-weather road? Do they have network connectivity, power supply? Because we believe those factors are what will make them similar on relevant dimensions. And then we can compare how the patients from those locations behave before and after vision centers open to give us the effect of vision center. And all of this was embedded in a statistical model. I don't want to get into too much of detail, but it's a panel data set. So we are observing these census locations denoted by I in this equation over repeated time periods, which I'm denoting using T. And in our case, every T is a month and every I is a census location. Typically a village, but could also be a habitation, which is lower than a village. And the variable of interest to us is this VCIT, which says whether a vision center was open in time period T at a census location I. So this will be 0, 1 variable. which then the difference between the 0 and 1 will give us this delta will give us the impact of the vision center. And we are going to allow for or control for all other outreach activities that are happening in this network, most importantly, camps, because patients are visiting camps, and we do not want the effect of camps to confound the effect of vision centers. And the Y variables are our interest outcome variables, dependent variables, which I will take you through one by one. There are several of those. And then there are more covariates here in capital X, which I'm going to skip in the interest of time, but the paper has the details. So this is the standard difference in differences model. We have what we call as census location fixed effects and time fixed effects to allow for the fact that there may be idiosyncratic factors associated with a certain village or a certain time period. And again, we don't want them to confound the true effect of opening of a vision center.
Saurabh, very quickly, that TIT, was that a time trend?
Say that again?
The TIT term, the
third. I should have talked about it. So yes, you're right. So I talked about parallel trends, and in some cases where parallel trends assumption may not be satisfied, we are going to allow for different trends in the treatment and the control arm. So that is what this interaction is capturing. Thank you for raising this question.
Okay, all right, thank you.
Because as a organization that's running vision centers, you may end up choosing locations where the impact is the maximum, where the trend is of a particular type. And so we are allowing for that possibility. Thank you. Okay, so this is, again, looking at the treatment and the control group and the trends in them for the overall visit rate as captured by number of visits per 1,000 people in a certain census area. Okay, so what you're seeing, that the red line is, or let me say this, the light thin red line is the control group. There's a certain trend which is increasing. Then the solid red line that you see, or curve that you see here, is from the treatment group. And you can see this 0 is the time at which a certain location got the treatment, meaning got the vision center. The two trends are fairly indistinguishable from each other. And the moment they get this treatment, you can see that there is a significant increase in the number of visits that are happening from the treatment locations as compared to the control locations. Okay, so this is just a beginning evidence to say there looks like some effect. Okay, and we would not have been able to capture this effect purely by looking at treatment data, because there is an upward secular trend in all locations. People are seeking more and more care over time. And so it's important to subtract out the secular trend, which can be captured by the control group. But again, this is not a definitive piece of evidence. It's just the beginning. And what I'm going to show to you now is the estimation results from the models, one by one, for different outcome variables. So the first variable of interest is overall visit volume. So the question here is, did the opening of vision centers increase overall patient volume in the network, which means did we expand access to our population? And then we'll try to break open that network effect into two: what happens at the hospitals and what happens at the telemedicine centers. Okay, so if I look at the first column, the way to read this is opening of a telemedicine center within 10 kilometers of a census location increased 2 visits, resulted in 2 additional visits per 1,000 people from that census location, compared to a similar census location elsewhere that did not get a vision center or a telemedicine center. So 2 additional visits per 1,000 people. Okay, that's the effect size at the entire network level. Now that 2 is capturing a combined effect of at the telemedicine center itself, the increase was 2.32 visits per 1,000 people. But at hospital, there was a reduction in visits of about 0.28 visits per 1,000 people. Okay, so overall in the network, there is increase, but there is a greater increase at the telemedicine center, and a reduction in visits at the hospital. Now, these numbers may not mean much. What is 2 visits per 1,000 people or 0.28 visits per 1,000 people? And so we compared it with average monthly volume from that census location to the hospital. And what we found is that this represents about a 5% reduction in hospital volume. So this is what we are calling a substitution effect. Okay, so a simple way to think about this is about 5% of visits that were happening to the hospital from a certain census location reduced or stopped because a telemedicine center opened closer to that census location. On average, 5% reduction. And the overall increase in the network is 30%, right? So what it is telling you is that the augmentation, the demand augmentation effect is about 6 times greater than the substitution effect. So huge expansion in access and some substitution effect. And if I now remove out referrals, because this hospital volume is also going to be inclusive of referrals, and as we said, opening a vision center may actually increase hospital volume because of referrals. So if I subtract out referrals, the substitution effect is slightly larger, it's 7%, but really not much of a difference between the second and the third column, which is also suggesting or indicative of the fact that not too many additional referrals were generated because the vision center opened. Okay, that's something to keep at the back of your mind. In the absence of this data, if I think, just imagine what telemedicine center is doing, some of us may imagine that, oh, a lot of patients will get identified, they may have complex conditions, and I'll start generating a lot of referrals to the hospital. But at least in this context, we don't see that to be happening too much. Lot of overall increase in patient volume at the telemedicine center and some small substitution at hospital. So sum total, what you can take away from this slide is maybe a lot of this increased volume of patients is for simple ailments that do not require a lot of referrals. Okay, that's like a provisional conclusion that we can draw for now. Shubhangi has asked a question: how do you capture referrals with the patients? Yeah, good point. Arvind had a tick box where if a patient was referred and then that patient actually showed up at the hospital, there was a mark in the data set itself, the medical records. Now, it is possible that this is an underestimate of the referral because not every referral is appropriately accounted for. So that is a limitation of retrospective data, but it is definitely not patient recall. We did not touch patients at all. We did not go to them, did not ask any questions to the patients. Okay, that's the overall effect. And then we can start splitting it further into, the first split we did is, okay, how many of these are new patients? How many are returning patients? Because one can imagine that opening of this telemedicine center really increased awareness, and patients who had never ever thought about getting eye care, they start to come to the telemedicine centers. And the other is, I once went to the hospital, but it is so far away, so I don't want to make too many return visits to that far away hospital. But if a vision center open up nearby, I may make return visits, more return visits. And so what we found is overall, there was a 30% increase that I showed you in the previous slide. 60% of that increase was due to new patients, and 40% of the increase was because of returning patients. So again, far more increase in new patients than returning patients. Interesting. I mean, so this may also indicate that much larger barriers are being overcome in terms of patients who never ever accessed my system are able to come because of this vision center that opened near to their community. The other split that we did was to look at simple versus relatively complex patients. Again, I'm using the word complex here with caution because in our analysis, we did not include chronic ailments such as diabetic retinopathy, glaucoma, which also contribute relatively low volume. But here in this analysis, we are comparing general eye checkup or simple vision defects that can be corrected by glasses or refractive errors, to slightly more complicated ailments such as cataract. Okay, so ophthalmologists in this room, pardon me, I know you will think cataract itself is very simple, but it presumably slightly more complicated than just refractive errors. Okay, so general patients and cataract patients. Again, remember that overall from a census location, there were 2 additional visits, right? And 30% overall increase because of telemedicine center. When I split into general and cataract patients, I see that the general patients, the increase is 50%, whereas for cataract patients, the increase is 25%. So smaller increase, percentage-wise, smaller increase due from cataract patients and a relatively larger increase from general simple patients. Similarly, when I look at substitution effect, slightly larger substitution effect, up to 7% for simple patients, and a smaller substitution effect for these slightly more complicated patients, cataract patients. Okay, so we are seeing differential effects. And again, one interpretation of this is patients have a sense, they know what the relative capabilities of these 2 locations in the healthcare network are and what my problems are. And so I may be self-sorting. If I think I have a simple problem, I'm more likely to go to telemedicine center and many more of them and substitute away the hospital visits. But if I have a slightly more complicated problem, the substitution effect is lower. That's one interpretation of this result. Again, all the interpretations that I'm providing are ex-post interpretations because we have not asked questions of patients. So there's no qualitative component to this study. Then we said, okay, visits is one thing, but do they get any corrective actions after they visit? And so again, for simple patients, general patients, we looked at glasses prescriptions. Is there an increase in the number of prescriptions that people got? And for cataract patients, we looked at actual surgeries. And again, interestingly, we do see a substantial increase in number of glasses prescribed or number of patients who got prescription of glasses, about 19-20% increase. And assuming some dropout, because not everyone who's prescribed glasses may actually get glasses, still, this is really where the impact is happening because of vision centers. These are all incremental, remember, compared to another location that did not get a vision center, but is otherwise very similar. Interestingly, we do not see such an effect for cataract surgeries. Meaning, again, if I were to compare 2 locations, very similar, except one got a vision center, another did not get a vision center. This location does not contribute any additional cataract surgeries as compared to this location that did not get a vision center. Now, notice at the same time that when I have a CAMPS variable in it, that has a significant positive effect on the cataract surgeries. So a census location that got a CAMP within 10 kilometers in the same time period had a significant increase in cataract surgeries from that location, but the vision center did not. Okay, so this is interesting. Again, patients are perceiving different channels of care differently, possibly. For simple ailments or for cataract related visits and maybe examinations, they are going to vision centers far more. But when it comes to surgeries, they are still relying on the older channel, which is CAMS. And from CAMS, they are going to hospitals for surgeries. Note that no surgeries are happening either at the CAMS or at the telemedicine centers. These are just acting as funnels to go to the hospital where the actual surgery is happening. Okay, and then we also looked at the cost side. And the story here is that there is no additional costs that patients had to bear. In fact, there was some reduction, but it was not statistically significant because of the opening of the telemedicine center. So it's not imposing additional cost. Distance-wise, obviously, there is a huge reduction. That is obvious. And to the extent that there is a travel cost or an indirect patient cost associated with distance, there would have been a reduction in patient cost that we couldn't directly measure. But from the point of view of money that patients give to Arvind, there is no change, statistically significant change. Okay. Last few things. So this is a complicated slide that is showing how these effects that I described of telemedicine centers varied spatially depending on the distance of the census location from the vision center and distance from the hospital. And so you can imagine, right, a patient who is deciding whether to continue going to the hospital or to go to a vision center. If the vision center is very close by and the hospital is very far away, that's where you expect most increase in the visits. And so that is captured by this blue line here. So the dotted blue line corresponds to patients who are 5 to 10 kilometers away from the telemedicine center. And the solid line is patients who are 0 to 5 kilometers away. So, and then the first graph is capturing the overall network visit rate. And what you see here are 4 distances of the census location from the hospital. And so I'm not going to go through all the results here. There are many, many results, but let me just take one of them, okay? Which is, if I look at this location, okay, this location is about 25 to 50 kilometers away from the hospital and 0 to 5 kilometers away from the telemedicine center. So that has a significant increase in patient visit rate because they find hospital to be far away and the vision center to be close by. And that increase is greater than the increase experienced from patients who are 5 to 10 kilometers away. So this differential is saying that patients are equally away from the hospital, but slightly farther away from the telemedicine centers. That reduces the effect of opening of a telemedicine center. Okay, so that's the way you want to think about these graphs. Again, in the interest of time, I'm not going to go through all of them. And then what you see similarly is you can do a hospital visit rate effect differentially for different census locations. And the substitution effect, which means a negative effect on the visit rate, is experienced much more, again, intuitively, for locations which are farther from the hospital, 25 to 50 kilometers, 50 to 75 kilometers. And doesn't matter whether the telemedicine center is whether 5 kilometer or 10 kilometer away. But these locations which are far from the hospital is where the substitution is going to happen. Interestingly, this is a complementarity effect, meaning a location that is 5 to 10 kilometer away from the vision center, but not very far away from the hospital, 0 to 25 kilometer, actually sees an increase in hospital visit rate. So we think this may be something like an awareness effect, that I know there is a hospital that is about 25 kilometers away, but I get to know more about the hospital when a vision center opens near me. And then I say, okay, you know, that hospital is not too far away. I've learned about it. Let me go to the hospital. So that's where you may see awareness or a marketing effect for these types of locations. So again, a complicated story when we look at these spatial effects. Happy to talk about them later, or the paper has more details. To summarize, okay, what is the overall effect of vision centers on patient access behavior? Largely positive effect. So vision centers increase the number of patient visits to the network, far greater than the number of increase that you see through camps. But the story is mixed, that you do not see that much increase in cataract visits as compared to general visits, and you see no increase in cataract surgeries. So the way to think about this is whoever actually wants to get cataract surgeries done were getting them done whether a vision center opened near them or not. So no effect of vision centers. So likely most impact that we are seeing here is patients who are generally well, have minor problems, still may have vision impairment, and they are getting glasses that they otherwise would not have gotten because the vision center opened. And then these effects vary by the spatial nature, the distances from the vision center of patients as well as the hospitals. So I'll stop here, and I know there are some questions. I'll tell you what we are trying to do now after this is look at other outcomes of interest. So one hypothesis is that vision centers may also lead to early diagnosis, and I may start seeing patients at early stages of more chronic conditions. Similarly, vision centers may improve follow-up visits after a surgery or after, let's say, again, some chronic treatment was given to them. Those are questions for further inquiry. We haven't yet gotten done with those. So with that, I will stop, and I'm happy to answer any questions.
Yeah, we have many questions lined up. So
Okay.
I think I'll have one question first I want to ask is how is the control group data has been captured? Means the where the vision centers are not located. Is it from the Arvind medical record data or how?
Absolutely. So all patient locations are captured from Arvind medical records,
Okay.
all patient locations. So this is where I said the address. Now, the trick is for these addresses to be mapped to a standardized census location. Because for those census locations, I have other information. So all these demographics, road connectivity, medical facilities, this is coming from census location. But the challenge is the address is typically given very crudely, next to this function hall or behind a temple and then some village name. So it took a lot of time to map these addresses to census locations. Once we could do that, we relied on far richer data about these locations that Arvind's system did not have. So that's the census location data.
And was there any difference in the visual acuity between visual acuity data was also taken, right? So was there anything like visual impairment and blindness?
We did not. So those are the things that we want to study. So anything that describes the patient's vision at presentation, we haven't looked at in this project. That's a good question. We just controlled for some of those variables, but didn't look at them as dependent variables.
Yes, Raj.
No, thanks, Saranga. There's a wonderful presentation. There's so many questions, but I would like to prioritize a few.
Yes.
Actually, it would have been good if I had been able to ask. I didn't raise my hand much earlier, but when you say the treatment arm, the telemedicine center, vision center. So, just to clarify, there was no vision center earlier. It was both the vision center with the telemedicine center, which was inaugurated, right? It's not about an addition of a telemedicine center. Then it becomes difficult to.
Super, Raja. So you're right. And so just for everyone else's benefit, let me say that there are two effects happening here, right? One is just pure access effect, that there is some healthcare facility that has opened closer to patients. And the second is the telemedicine capability that allows patients to talk directly to a high-level healthcare resource, an ophthalmologist. Now, ideally, one would want to say the effect of telemedicine should be over and above just a center opening. And then I gave them telemedicine capability. Unfortunately, in Arvind's case, that was not available. You're right, Raja, that this is the combined effect of access plus telemedicine.
Yeah, but it still gives us information, right? So it's still a lot of information for us to learn from, and in fact, deep dive. But what Padmaja also mentioned, I have just an elaboration of that. While cataract surgery rates did not change, cataract diagnosis changed. Obviously, more footfalls, even in a primary center, can have a diagnosis.
Correct.
But were there more earlier stage cataract diagnosis being made? It's not an uncommon thing probably. And the felt need from a patient for a cataract surgery may be, less. So if most of the cataracts which are diagnosed in a vision center are early cataract, and the patient feels, I could still hang on to it. It's just a cross-sectional study. You haven't done a longitudinal study probably.
No, Raja, just second. This is actually panel data, right? So which means we have data over 10 years. It's not cross-section in the truest sense.
Oh, okay. Okay.
So you are right. I mean, these were exact same questions that all of us raised, us as researchers and, Arvind people as those who are running this, because the fact that the cataract surgeries did not increase, this was quite surprising to them. And so one likely explanation is, as you are saying, we just ended up finding them earlier, and that's why the visits are increasing. But the decision to do a surgery would be, at an appropriate time. So you're not really increasing surgeries, you're just shifting them in time.
Yeah, thanks, Sarang, and sorry, Anindya and Shubhangi also have questions. But
Yes.
one last
Yeah,
point.
sure.
I don't know. It's not probably easy to answer from this data set, but a camp effect is going to be much more. It will have a compounding effect on other patients also who have early cataract, but if you had gone alone to a vision center, may not have immediately opted for a cataract surgery. But you have two very late cataracts in a camp setting, and you see a bus going, two people are going, let me also catch on to this bus and get my cataract operated, versus in a vision center, that social or psychological feeling of being alone for having to go somewhere versus a camp event. It's just a thought process. I don't know what it is.
That's a very good hypothesis. I mean, what I will say is this camp effect that you see, 0.19, which is highly significant, is not only people who attended the camp. So Raja, your point is absolutely correct. We're looking at all patients from that census location where camp was conducted who got the surgery. So this may include the network effect that you're talking about. Quite possible. And it will be an interesting micro study to conduct about this social aspect of healthcare seeking.
Yeah, thank you others for giving me the opportunity. Over to you, Shubhangi and Anil.
Yeah, Anandya.
Hi, Sarang. Thanks for that. So fantastic work. I really enjoyed the whole presentation. I have essentially 2 points. One query, and the other one is more like an observation. So the query here is this substitution is very interesting. That for camps, and I'm here piggybacking on Dr. Raja what he described. What I was thinking that. Often in newspapers and advertisement, I see that many of these hospitals will announce camps only for cataracts.
Correct.
So they will go to the villages. So I mean, the way you are treating them is like these camps are more general purpose things, out of which this shift is happening. So I was just wondering whether there was some kind of, sample selection happening. I mean, self-selection happening out of the patients because the hospital push this idea that, cataract is a problem that you can get rectified if you come to this camp. So therefore, the switch that we see is not really by the consumers, I mean, by the patients. It's more just driven by, the selection effect created by the hospital in question. Is it possible?
It is absolutely possible. In fact, what we are saying is not very different from what you're saying. See, we do not know the mechanism, correct? All we know is this effect. And one thing I will qualify to what you said is at Arvind, there are some cataract camps which are marketed or whatever, announced as cataract camps, but a large majority of them are just camps. So it's not so much as the advertisement, but the historical experience that people have. What happens after you go to a camp? One big thing that happens is people will be told that you need a cataract surgery and a transportation will be arranged and you'll be taken for surgery. So that's such a salient thing that happens in the community. Right. That although people are getting refractive errors checked, although they are getting glasses, all of that is happening. But cataract is important. So I agree with you.
From that point of view, then this is kind of expected given the institutional knowledge that these camps are supposed to mostly cataracts to begin with.
That is correct.
So therefore results are consistent, at least with
consistent.
But I think two important thing is that the new patients, that access has definitely telemedicine center has improved the access to the new patients who would not have otherwise come. That I think that 60% That is something very, very interesting. Subhangi, your question?
Sure.
let me
Dr.
just-
Padmaja, can I ask one more question?
Yeah, please, please.
No, so Anindya, let me actually respond to you, because we had such elaborate discussions on just this one column of results, okay? Because, and folks at LV Prasad will probably understand, they were just not willing to believe that telemedicine centers have no effect on cataract surgeries. And the reason was because they said every month, I know how many patients were referred by the telemedicine center to the hospital for cataract surgery.
Yeah.
And that data is real. So how can you say there is no effect? And so we had to explain to them over many, many meetings that what you are seeing is only the effect at locations where telemedicine center opened. But what we are doing is we are subtracting out what would have happened in these locations if telemedicine center had not opened, which you cannot observe in operational data, right? And so when we subtract that out, we are seeing no effect, which means patients who want cataract surgeries will figure out a way to get cataract surgeries, whether telemedicine center or not. So I just want to highlight that point, that it may sound surprising. And the other thing to say is, in a sense, it's a limitation of telemedicine centers, because one of the underlying questions when we started the study was, should we stop conducting camps once we have telemedicine centers? And what this result is saying is, you may, but be careful, because patients who are, who have grown up on camps for cataract surgeries, may find it hard to switch to this new channel unless you put additional effort and tell people that, hey, even if you get tested at telemedicine center and we tell you have cataract, we will arrange for transportation and we'll take you to the hospital. So that's sort of an additional implication. But okay, over. We'll go back to you, Anindya.
Yeah, the other thing I was thinking is, if you had, I mean, I guess you already said that you did not have that data at that point of time, that entry-level visual impairment and outgoing visual impairment, and how that, changes across the intensive margin and the extensive margin, in the sense of existing
patients and
versus the new people who are being brought in. That would be, I mean, this is already fantastic, but that would be like, understanding the market expansion effect. I mean, clearly this is not being sold here. I'm using the market more like a consumer base kind of idea. So that would be very nice beyond this. So that was just, but very nice.
Thank you.
Very enjoyable.
Yes, Subhangi?
Prof, I just have a very quick question. I wanted to ask about the matching technique that you have used. So I just wanted to ask if you have also used distance as a measure in the characteristics while you like identify your control group of patients.
Distance from what?
So if there is a when I'm looking at a pink dot and when I'm looking at a blue dot, so like you're matching on a set of characteristics, but the patient who is in the pink dot is falling in a particular circle, and the patient who is in a blue dot might have similar characteristics to the one who has the pink dot, but he can be in a he can be located at a far away distance, like the his location can be quite far away. So then the impact of, because we are testing the impact of opening of a vision center, so in that terms I wanted to know if
Understood. So Shubhangi just got, I think there's an echo. So it is, so these blue dots, the control locations, are far from this location that got the telemedicine center. You are correct. But what we are saying is, what if a vision center had opened within 5 to 10 kilometers of this location, which otherwise is identical to the location in the pink pin? Otherwise, they have same power supply, they have same road connectivity, they have same network connectivity, they have similar median income. It's just that one location got the telemedicine center and another did not get. So the distance that you are referring to does not matter that much, because we are not expecting these people from blue to go to this telemedicine center. That's not what we are measuring.
Okay. Yeah. Okay.
And the matching technique, we didn't actually do matching as much as we did propensity score weighting. That was our main technique. And then we did robustness around different matching, like the caliper and all those other things.
Okay. Thank you.
Thanks.
So I think, yeah. Anandya was mentioning, okay. So I think that's an excellent overview of, actually it's all looking toward operational lens, I can say, because it's a big learning for us, that substitution and demand, I think demand augmentation. I think these are the ways where we can actually look at the impact much more clearly, both at the policy making. For example, probably this has given us a direction to even to the hospital, how the vision centers are able to take care of the minor problems, probably even in our setting in LV Prasad also, out of 235 vision centers. So we see that 80% of the minor issues are taken care by the vision centers, and we actually make them like a referral, green color we say. Green referral means they're managed by teleconsultation alone at the vision center. And we used a red and yellow color, which requires urgent and semi-urgent referral. So by doing capturing color-coded referral, what we have found is from the baseline, which was only 25% of this red and yellow color was around 16%, were actually going to the next level of care. But after doing telemedicine and by tracking a color-coded referral, we found that 80% of this urgent care which required are actually able to reach to the next level of care. So I think telemedicine has the huge advantage if we can capture appropriately in the referral, and the impact is going to be enormous. And definitely having an operational lens like your expertise, I think it's amazing to see how these things can be to impact and maximize our patient care. Thank you.
Thank you so much, Dr. Padmaja. Thank you for the opportunity and wonderful questions. I really enjoyed presenting and answering those questions. Thanks a lot.
Thank you. Thank you.
Yeah, thank you, Sarang and Padmaja. Bye.
Thank you. Bye-bye.